Good evening, and welcome to this month's Bariatric Happy Hour. I'm your host, Faiz Shariff, and joining me is my fantastic co-host, Dr. Juyeon Park. This is your monthly webinar held on the fourth Thursday of each month. During these sessions, we take a closer look at seminal papers that have shaped our field and alternate these with sessions focused on technical aspects of metabolic surgery. And beyond these webinars, the Bariatric Surgery Training Committee also runs the Fellows Project on the first Friday of the month, a monthly session dedicated to reviewing key topics from your core curriculum. These sessions count towards your ASMBS Fellowship Completion Certificate, so we hope you're taking full advantage of those. Now, without further delay, let's introduce our guest. Tonight, I have the distinct pleasure and honor of introducing a remarkable surgeon, a visionary scholar, and a global leader in metabolic and bariatric surgery. Joining us all the way from Finland, Dr. Paulina Salminen. It is 3 a.m. where she is, and we are incredibly grateful she's with us tonight to share her insights and experience. Dr. Salminen is a PI behind the SLEEVEPASS randomized clinical trial, a long-term comparison of sleeve gastrectomy and gastric bypass. She shared this impactful work during the 2024 Mason Lecture at the ASMBS annual meeting in San Diego in a talk titled Trials and Tribulations of RCTs and Long-Term Follow-Up, the Story of SLEEVEPASS Trial. And if you haven't had a chance to watch it, I highly recommend you do so. The video is available on YouTube, and at some point, I'll drop the link in the chat box. What made that lecture stand out wasn't just the outcomes. It was very candid, behind-the-scenes look into what it really takes to conduct a long-term RCT, patient retention, evolving protocols, and navigating real-world complexities to produce a high-quality evidence. So a little bit about Dr. Salminen. So her academic journey began right here in the United States, where she graduated from Bariatric High School in California in 1988. She then returned to Finland to study at the University of Turku, completing her Bachelor of Medicine in 1993, her MD in 1997, and ultimately her PhD in Medical Sciences in 2007. After years of clinical excellence and academic leadership at the Turkey University Hospital, she was named the Chief of Surgery in 2013, and in 2019 was appointed the Professor of Surgery at the same university. She currently holds the prestigious title, I hope I don't get this wrong, Sigrid Juselius Professor of Surgery. But her impact extends well beyond Finland. She is the current president of the IFSO European chapter and has served as the past president of both Finnish Surgical Society, Finnish Society of Metabolic Bariatric Surgery, and I'm sure I'm missing a whole lot of other things here, but she holds an honorary fellowships from both the American College of Surgeons and then the American Surgical Association. She serves on multiple editorial boards for multiple high-impact surgical journals. To date, Dr. Salminen has published over 300 peer-reviewed articles, many of which have shifted global paradigms. Among them is the APAC trial, a landmark randomized controlled trial evaluating non-operative management of acute appendicitis. This study didn't just influence guidelines, it was selected by the JAMA editors as one of the top 10 articles of the decade from 2010 to 2019. Tonight, she brings her signature clarity and warmth to walk us through the journey of SLEEVEPASS and to share her reflection on patient-centered care, evidence generations, and global surgical leadership. We are truly honored to have her here with us. Please join me in a warm welcome to Dr. Paulina Salminen.
Thank you so much, Faiz, for your kind words.
Right. So now, Dr. Juyeon Park, do you want to introduce our next guest?
Our next guest is our fellow presenter. We have here Dr. Nathan Haywood. He's originally from Fairhope, Alabama. He did his medical training at the University of Alabama in Birmingham, Alabama. He did his general surgery training over at University of Virginia, Wahoo Wah, and now he is the current fellow of the Advanced GI MIS Bariatric Surgery Fellowship at my alma mater for my fellowship at University of Tennessee, Knoxville. Go Vols! So thank you, Nathan, if you can share your slides.
All right, thanks so much, JP, for that introduction. We're going to go ahead and get started, and we're so excited, to have our distinguished guests. And the topic of the day is the SLEEVEPASS trial. So sleeve or bypass, SLEEVEPASS randomized controlled trial, and we're going to go over 5, 7, and 10-year data. So the SLEEVEPASS trial, a little bit of background. This study was published in 2018. But actually, the collection period was about 10 years before that, or just less than 10 years before that. And around this time, laparoscopic sleeve gastrectomy was really growing in popularity. In 2013, the sleeve gastrectomy surpassed laparoscopic Roux-en-Y gastric bypass, the most commonly performed metabolic bariatric surgery. So the objective of the study was to determine, and this is the initial 5-year paper, was to determine whether a laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass are equivalent for weight loss at 5 years in patients with morbid obesity. So the study design, this was a multi-center, multi-surgeon, open-label, randomized controlled trial. Again, it was conducted between March 2008 and June 2010 in Finland. It included 240 morbidly obese adults, let's say age 18 to 60. And of those 240 patients, there were 121 sleeve gastrectomies and 119 Roux-en-Y gastric bypass. The primary outcome here was weight loss, and that was reported as the percent excess weight loss at 5 years. Important to remember, there were pre-specified equivalence margins, and that's -9 to +9% excess weight loss. So the pre-specifications were that if the weight loss were within that -9 to +9% margin, that would be considered equivalent in terms of clinical significance. Secondary outcomes here were resolution of comorbidities, improvement of quality of life, morbidity, and mortality. We're going to get into a little bit of the results. I think one of the really astonishing things about this paper was the follow-up rate. So at 5 years, 80.4% follow-up. That's pretty amazing. If you look at the initial baseline characteristics, the groups were similar. Mean age was 48, and the mean BMI was 45.9. In terms of the primary outcome at 5 years, the percent excess weight loss after sleeve gastrectomy was 49%, and after Roux-en-Y gastric bypass was 57%. You can see that shown in the chart here at 5 years. And that's a difference of 8.2%. The 95% confidence interval was 3.2 to 13.2. And because that confidence interval extended both above and below the pre-specified equivalence margin of 9%, it did not meet what was designated as equivalent outcomes between the two groups. So on the other hand, because although the weight loss was slightly higher for the Roux-en-Y gastric bypass group, it was not clinically significant because the confidence interval did not fall on the outside of that +9% margin. So yeah, I think the findings from this paper were that the weight loss after the sleeve gastrectomy was neither equivalent nor different from the Roux-en-Y gastric bypass. We'll get and this is a kind of a schematic on the right here dictating that -9 and +9% pre-specified equivalence margin. And you can see here that at 5 years, 3 years, 1 year, and at half a year, the 95% confidence interval extended both above and below that 9% equivalence margin. So in terms of secondary outcomes, the gastric bypass did have better resolution of hypertension compared to sleeve gastrectomy at 5 years, and that's based on the number of medications used. There was no difference in type 2 diabetes mellitus resolution, dyslipidemia, quality of life improvement, or late morbidity. So the conclusions from this first 5-year paper was that the sleeve gastrectomy compared to Roux-en-Y gastric bypass did not meet criteria for equivalence in terms of percent excess weight loss at 5 years. And although the Roux-en-Y gastric bypass did have a slightly higher percent excess weight loss, the difference was not clinically significant. So clinically significant, again, based on that equivalence margin of 9%. So major strengths of this paper, I think it was at the time was the largest randomized controlled trial comparing sleeve gastrectomy and Roux-en-Y gastric bypass, and it had a very high degree of follow-up, greater than 80%. And it really did demonstrate the long-term durability of both of these weight loss surgeries at 5 years. Some of the limitations at the beginning of the study, it was reported that there was relatively few bariatric surgeries that were being performed in Finland, and there was the possibility of the learning curve with new adopters having some impact. And then the number of patients lost to follow-up did preclude a strict intention to treat analysis. All right, we're going to move on now to the 7-year outcomes, and that was published in 2021. Objective here, similar to the 5-year data, was to determine whether the sleeve gastrectomy and Roux-en-Y gastric bypass were equivalent in terms of weight loss at 7 years, but this paper did have a special reference to quality of life outcomes. So at the 7-year time point, 75.8% completed follow-up. Again, very good follow-up. The percent excess weight loss after sleeve gastrectomy was 47, and after Roux-en-Y gastric bypass was 55%. Again, a difference of 8.7%, with that 95% confidence interval going from 3.5 to 13.9. At the 7-year study, the comorbidities were not reported. So the comorbidity data was not in this 7-year paper, but it is going to be popping its head up again in the 10-year data, which I'll show you here in a moment. And the weight loss data you can see there on the figure to the right. So major conclusions from the 7-year paper in terms of the weight loss, pretty similar to the 5-year paper. The sleeve gastrectomy and Roux-en-Y gastric bypass were not equivalent, again, because that confidence interval extended both above and below the 9% pre-specified equivalence margin. And although the gastric bypass did result in slightly greater weight loss, it wasn't clinically significant based on that pre-specified equivalence margin. In terms of quality of life, there was no difference in long-term quality of life scores between the laparoscopic sleeve gastrectomy and the laparoscopic Roux-en-Y gastric bypass. That's at 7 years. The disease-specific quality of life did improve after bariatric surgery. So these patients had quality of life scores both before and after bariatric surgery, and that did improve. And those were compared to a age and sex standardized general population. And when the post-bariatric score, quality of life scores were compared to the general population, they were slightly lower, but still improved from their quality of life before surgery. All right, now we're going to move on to the 10-year data. That was published in 2022, and the objective here, similar to the 5 and 7-year data, was to compare the long-term outcomes of weight loss. But in this 10-year data, there was a special focus on comorbidities. So it looked at remission of obesity-related comorbidities and the prevalence of GERD, endoscopic esophagitis, and Barrett's esophagus after laparoscopic sleeve gastrectomy and Roux-en-Y gastric bypass at 10 years. So excellent follow-up here. 85% patients completed the 10-year follow-up, and 77% underwent upper endoscopy, which is pretty astonishing. The percent excess weight loss for the sleeve gastrectomy group at 10 years was 43.5% and 51.9% after laparoscopic Roux-en-Y gastric bypass. That's a difference of 8.4% with a 95% confidence interval, not 3.1 to 13.6. Again, you can see that in the figure to the bottom right of your screen. So some results for the 10-year data. There was no difference. This is comorbidity specific. There was no difference in type 2 diabetes mellitus remission at 10 years between groups. That's 26 compared to 33%. No difference in dyslipidemia, which you can see there, and no difference in resolution of obstructive sleep apnea. Similar to the 7-year data, or similar to the 5-year data, hypertension scores hypertension remission was superior after Roux-en-Y gastric bypass compared to sleeve gastrectomy with a p-value of 0.04 at 10 years. So on upper endoscopy, esophagitis was more prevalent after laparoscopic sleeve gastrectomy. It's 31% compared to only 7% after a laparoscopic Roux-en-Y gastric bypass with a p-value of less than 0.001. There was also higher rates of GERD symptoms and PPI use in the sleeve gastrectomy group. But important here, there was no difference in Barrett's esophagus between groups. And then this paper also examined 10-year reoperation rates for the sleeve and Roux-en-Y gastric bypass group, and those were similar, so no difference in 10-year reoperation rates. So in conclusion, at the 10 years, the sleeve and bypass were not equivalent in terms of percent excess weight loss, again, because that 95% confidence interval extended above that 9% pre-specified equivalence margin. While the bypass had higher weight loss, it did not meet that clinical significance because, again, that 95% confidence interval extends above and below the pre-specified equivalence margin. Very sustainable 10-year weight loss was seen in both groups, about 50% excess weight loss, which is excellent. And while esophagitis was higher in the sleeve gastrectomy, there was no difference in rates of Barrett's esophagus. This study really demonstrated a much lower incidence of Barrett's esophagus than previously been reported in other trials, which I think previously had been up to 17%. So this is important data. So that's all I've got for going through those papers. And I'm going to stop sharing my screen.
Thank you so much, Nathan. And Dr. Salminen, if you want to share your screen and take it from here.
Yeah, I'm on mute. Okay, did you want to discuss some of the questions now, or do you want, because my presentation is more, of course, along the lines that like behind the scenes, but also with how to do, like, how is the idea to do randomized control trials? So maybe we start with that and then we have the discussion as you have planned, right?
Sure. Or we could,
I
mean, I could just ask you a couple questions on the SLEEVEPASS trial. It's something that, I've been dying to ask you. So many
Sure.
of the listeners today are trainees and early career surgeons who are still forming like the clinical instincts. From your long-term data in SLEEVEPASS trial, what do you think they should take away when it comes to counseling the patients? I mean, all of us, they're going to be starting their new careers, say in August, I guess, August to October time. So what do you want them, especially now there is a lot of, if you look at the FASMBS data on how many sleeves are being done, it's still in the majority. And it's seen as a default. So what do you think they should take away from the long-term data that we have right now?
That's a very good question. And even though so far the largest randomized trial with the longest follow-up, it's still sometimes difficult to say. I think the 10-year data clarified a lot of things because you do have to look at reflux. And I thank Nathan, that was a very excellent summary of the of all the studies. But I think the reflux issue is one thing that you do have to take home and again, looking back, we did exclude severe GERD, but it was, as be
It's okay, guys. She's going to be back. She might be going through a tunnel.
okay. Do you guys hear me okay?
Now we
Yeah,
did.
now I'm no. Yeah, I will. Yeah, I know. I'm actually going through a tunnel. So yeah, so it's a tunnel area. So if we're able to stop, I'm gonna stop like in a spot that because now I'm entering another tunnel. So probably, but like I said, the GERD in between the tunnels, I'm gonna say that GERD is a very important take message because that you actually see that the patients suffer from, and that's clear. That's the Achilles heel of a sleeve gastrectomy.
So, were any of these findings a surprise to you? Do you think she's there?
I think she's in a tunnel.
Okay, she's in a tunnel. We'll just wait for her to come back.
It is now I'm back. Hopefully you
Okay.
guys hear me now. I'm back, and it should be. And we're looking for a spot if possible. Okay, so like I said, it's that is one of the issues. And then again, if we would have excluded patients with a kind of a more severe form of GERD have a standardized definition, then maybe the reoperations within sleeve gastrectomy might have been lower. But then again, we're looking at some recurrent weight gain. So I think it is still, I am looking forward to our 15-year and 20-year data. We already have completed the 15-year data, and we're doing the endoscopy again at 20 years. Then I probably have to stop because the patients probably won't. They will not agree to come in after that. But they, strangely, we're able to get them for, and of course, that takes a lot of effort. And that's one of the key issues of doing randomized trials, because if we're treating a chronic disease, so we really need to see the long-term data. It doesn't really matter what the results are at 1 year if they are not sustainable at 5 to 10 years. So as we're treating a chronic disease, you need to have the long-term data. So, but that's the challenge. But maybe now at this point, we can continue the discussion, because I will, of course, address some of the issues in my talk, but I think Nathan nicely showed the part that the RCTs they always have to adhere to the original study design, and that sometimes is because you have really bound yourself with that study design. So I may not do another equivalence trial ever, so it is a bit tricky. So that may be the take-home message. No, honestly, it is just it is really a matter of focusing on when you're doing your study design. But I will now share my slides, just a bit of insight, and hopefully we're still out of the tunnel area. You guys see my slides okay?
Yep.
Okay, good. So I really did approach this in kind of an idea that because doing a randomized clinical trial is insanely hard. It takes so much time, it takes money, the energy put in, and then you really have to, that is really time consuming and arduous. But still, when you look at the scientific pyramid hierarchy, this is actually what we do if we establish treatments. So this is the effort we have to actually take. So these are my disclosures. So nothing really relevant to the current presentation. I am a fanatic data person. I think we need to have data to back up our clinical decisions. Maybe the most important disclosure is that it's really 3 a.m. in Finland at this time. So as you can see outside, I'm on the sun rarely sets, so it's actually quite pretty. So as Faiz kindly introduced me, I do a lot of journal work. So I've incorporated within my surgeon scientist career and all the kind of mistakes I've done. So and already at this point, I will say that before you start doing anything, please consult the people that have done similar studies and trials before, because you can always learn from everybody else's mistakes, and then you'll end up doing your own, but just don't do the same ones that somebody already did. So do your own mistakes. Okay, so I think this is just briefly what I wanted to share, that why do we need RCTs, and then my personal RCT bias, and how to conduct RCTs, what are the stages that you actually, and the challenges you're facing. And I wanted to show you a BGS paper that was actually looking at all surgical RCTs within 2 decades, that where they are produced and what is the quality, and then what's the important scientist that I within within medicine, but I think in surgery they have the care. Sometimes it is really evidence-based. So, do you guys hear me okay? Did I fade out just? No, okay, it's good. So, no, that's good. So, I really think evidence-based surgery, actually, I think that's a very nice quotation, that making the same mistakes, with increasing confidence over an impressive number of years. So please do not, we really have to, we're doing evidence-based medicine. So you really have to look at the data. And another thing is that sometimes there's this discussion that, okay, that study says that, very high quality research shows that this is the outcomes, but in my hands, it is very different. That's not true. It is, you have to look at the evidence. This is, we're doing evidence-based medicine. So everybody has to remember that. Of course, evidence-based medicine doesn't mean only the scientific evidence, but it all, of course, incorporates your clinical expertise, what the clinician knows. And then that you have to combine those two things in order to actually have your evidence-based medicine, because of course you cannot have an RCT on every single topic, and you need to have your clinical experience incorporated with the best research evidence, and that is how you actually create evidence-based medicine. So your clinical expertise is very valuable, but that cannot be the only thing you base it on, because the numbers per surgeon do not allow that drawing that strong conclusions. I will go a bit about the SLEEVEPASS trial, and this is actually it's a lecture, so which I was privileged to give in San Diego the year before. So this is actually part of my SLEEVEPASS study group, and I have to confess, and as I confessed in the recent lecture, that remember when you were joining congresses and listening to very important scientific and clinical talks, still remember the collaboration and networking outside the scientific program, because networking with your colleagues is crucial in your career development, both clinically and scientifically. I've learned so much from a lot of bright people, and to prove this is like one of the things that usually the ideas that one gets after 1 a.m. are not really that good. I think everybody can share that idea, but SLEEVEPASS trial was actually one of the ideas. So this is my already deceased colleague in the picture, Mikael Victorson, and we were sitting at a bar creating the flow chart for the SLEEVEPASS trial in 2007. So, and actually the original, I still had the original napkin that we wrote that on, but it actually got burned in the fire, and I will show that a bit later. I wanted to pop into appendicitis because that is the other field of my clinical research that I've been doing. These are the two main research fields, and also they are I do, in addition now, in addition to metabolic bariatric surgery, I still do acute care surgery. I used to do a lot of logical surgery, but there are only 24 hours in the day. So that's not possible anymore to focus, because you need to focus on the stuff you do in order to become an expert. So you have to kind of orientate what you actually want to do. So this is actually just not to go into the clinical details, because this is not a lecture about acute appendicitis and how to treat it. And remember, when we're talking about non-operative treatment, we're talking about uncomplicated acute appendicitis. But this is just to show kind of the idea of a research continuum. So we started on the bottom. There's the original APAC trial, appendectomy versus antibiotics, showing that, the majority of patients did not need surgery. And that was also at 5 years. And we actually have a 10-year data that's currently under peer review for that trial. And then we continued with the APAC number 2 trial, already trying to optimize the non-operative treatment. And I have to say that the APAC study group is they're all surgeons. So this is surgeons doing research on non-operative treatment. So remember that this also is for obesity. We have a lot of tools in the box right now, and we need to be able to use them. So the APAC number 2, the second step showed that oral antibiotics were sufficient. So we continued also at the same time, because already for uncomplicated acute diverticulitis, the data showed that even antibiotics may not be needed, and appendicitis is very similar to acute diverticulitis. So we did a pilot RCT, a double-blind RCT on antibiotics versus placebo on uncomplicated acute appendicitis. And as it was a pilot RCT, that one has a question mark at the end, because that just shows the idea that you need a larger non-inferiority trial, because that was a small pilot superiority trial. So now we are conducting APAC number 4, which is oral antibiotics versus placebo in an outpatient therapy, a double-blind RCT, which will define whether we even need antibiotics for uncomplicated acute appendicitis, which I think is the crucial question, because if we don't even need antibiotics, it's very hard to say that we would need surgery for all of those patients. And this doesn't mean all appendicitis patients. This is just the uncomplicated ones. So half of the patients will still undergo operation. And of course, the outpatient therapy was also already shown. This is an outpatient, so maybe we can also avoid hospitalization, which means that, of course, additional cost savings. Just to show you the research continuum, the next research question actually has to be somehow based on the previous research, and of course here our own research. So going forward, this is the fire I was talking about. So this is just to show that what strange things may happen and strange challenges in your while you are conducting your study. There was a terrible hospital fire at my hospital, and nobody was actually injured. So it was very costly, but nobody was fortunately injured. And that were it's where we had coach where it was destroyed.
We'll just give her some more minutes to join us back. It might be one of those other tunnels that she's going through. While she comes back, Nathan, I might just ask you as a guest, how do you think you would interpret the SLEEVEPASS trial? And okay, she's gone. She's gonna be back. How do you think you would interpret the SLEEVEPASS data into your practice?
I think that both are good options for the right patient. They both have pretty durable weight loss at 7 to 10 years, which is great. But again, yeah, I think that the GERD and the esophagitis problems after sleeve are certainly something that I'll, tailor my decision making based on the preoperative symptoms and comorbidities that the patient has.
Yeah.
It was pretty interesting for me to see that there wasn't really a difference in the resolution of diabetes. I was kind of surprised by that. I would have, guessed that the bypass group would have a little bit better diabetes resolution rates, but
I think there was Stampede trial that Phil Shower did. That's what it showed. That diabetes was there, and if I think in one of our talks she mentions this. Maybe the kind of type with diabetes, it is depends on how long you have had diabetes for the resolution rate. So I don't think she could tease out that data from there. But in general, so just tell us a little bit about are you going into practice and is it going to be a bariatric job? A little bit more about yourself until she
yep,
joins us and.
sure. Yeah, I'm going into like it's hospital employed practice in Central Virginia that will be general and bariatric. The bariatric volume is quite low now there, so I'm going to try to build that back up. But so it'll be a lot to start of, foregut and hernia and general surgery, and then I'm trying to get the bariatric volume back rolling.
Okay.
So.
And in terms of like, are you medically certified for like the ABOM? Are you going to be prescribing medications and stuff?
Yeah, I'm sitting for the exam this October. I'm studying for it right now, so I haven't done it yet, but that's in the works. So I'm going through the review courses right now and getting the CME required. I know the early bird deadline is coming up like July 10th, so
Right.
I'm gonna get registered before that.
I have to do the same thing. Faiz, do you have it? Do you have the DABS?
No, actually, I'm going to be taking, so I'll take it with all of you guys this time around. So I think
Like
it's
everyone's taking it this year.
yeah, it's imperative that we kind of take that, and it's just another tool in our toolbox. Um, and one of the questions I wanted to ask is like when with GLP-1s, you see a lot of our patients are now taking GLP-1s, and at least I see that's what I see in my practice. They come and then get the bariatric surgery, so that kind of muddies the water. And maybe we need a trial where we are actually looking at pure surgery, medications plus surgery, or medications before surgery, or medications after surgery. There is a whole lot that we don't know about these medications. What has been your, in your kind of realm of things? Have you seen a lot of patients that are coming now?
I personally am getting a lot of patients who are wanting medications first, trying it for a little bit, and then coming back to
Can you
me.
say a little bit how long are you keeping them on medications for?
A lot of them are trying for about 3 months, and then within that 3 months, either insurance fails
There
or
she is.
is she here?
There she
I'm
is.
Oh,
back.
welcome
I'm
back.
back. So sorry that was the
Okay.
connection.
There are a lot
So
of channels in Europe, especially in Finland, so we understand. We're just glad you're back. So,
yeah, I'm here. So
oh,
let
great
me
stuff.
continue. Let me
Yes,
continue.
please.
Hope you had a good discussion while I was doing that, trying to reconnect. So I got into the hospital fire and I was telling about the having a good acronym for your study. And that's why I wanted to share because initially SLEEVEPASS trial had only 4 letters per operation. So when you say that out loud, it actually doesn't sound that good. So I did say that out loud, SLEEVEPASS for the first time. And then I realized that we're changing the acronym before we are doing it and publishing it. So I'm really happy. So have a good acronym for your study. Then continuing on how to choose the study type. So I actually have a very brief flow chart on how to do your research and for this, let me just get you guys out of the way. So here this is a very simple flow chart. So if it's possible to randomize, you should really do a randomized clinical trial. because I think it is also a matter of focusing your energy, your time, and your funding on one relevant large RCT instead of doing multiple retrospective studies. So I think it's really a matter of focusing your energy in a correct way and where it actually has the most impact. So I think that's actually crucial. So focus your energy on a high quality research. And this is really, if you want to look into how to do a good study. So this is a BGS paper on that. So not to get into detail, but it is really good. So, and you're free to have the slides. I just wanted to show you, this is adapted from FASMBS. So kind of the idea of doing a randomized trial, because first you have to actually ask the correct question. And that is really a matter for a surgeon scientist, because I think clinical research actually has to be done by clinicians, because otherwise you're not able to ask the right questions. First, you have to identify the need. And that's actually sometimes quite easy. You actually have many interesting research questions that you could do. Then the tricky part is the number two, when you design the trial. And that is the phase that you really have to put your effort in, because if there's something wrong in this phase, you're actually just really shooting yourself in the foot, because then it's not going to work out. Nothing's going to come out of that pipeline that you can actually draw conclusions from if you do the study design wrong. So use time and energy and mentorship for that. Of course, conducting the research is very tricky because randomizing patients is very difficult. It's even more difficult in an acute care setting, but it is always difficult. You have to do that. I think disseminating the results is actually probably the easiest part if you've done all the other phases correctly before. Changing practice policy is extremely difficult, because we have good data showing that even with a harmful kind of treatment that you have a trial result, it still takes a median about 17 years for the trial to be implemented in clinical practice. So really you have to be patient and you have to focus on the active implementation. Then looking at, it is really a brick wall and kind of a hurdle after hurdle. It is really an amazing race with all the detours and U-turns and roadblocks, because it really takes time and effort. But I think still focusing on one good large RCT is much better than doing multiple smaller retrospective series. So like I said, otherwise you are really shooting yourself in the leg. Focus on designing the trial and use people that have done trials before, so it's not, you don't need to do the same mistakes over and over again. So focus on designing your study, as Nathan nicely showed and we briefly discussed before, is the equivalence setting. It is very tricky, and with the equivalence margins, not going into detail for that, but we of course had to define those somewhat arbitrarily, because at that time when we were conducting the study, there really was no long-term data on sleeve gastrectomy, so we actually had no idea what was going to happen. So you actually had to extrapolate some, that how you should actually do those equivalence margins. This also applies for the minimally clinically important difference, that you have to decide what is actually clinically relevant. So you have to figure that out, and then you have to balance that between the reality of how many patients you can have, because if your clinical relevance interprets into having 1,000 patients, that's never going to happen. So you have to be realistic and make sure that your study design is designed in a way that you're also able to conduct the research in a reasonable amount of time, because if your trial takes 10 years, it's going to be outdated way before when you actually publish it. So this is really everything you have to consider already at the designing phase of the trial. So that's clear. So this is what I wanted to show you as a BGS paper. I think is very interesting from 2 years ago. The Dutch colleagues were leading this, addressing the issue of surgical RCTs for 2 decades, that where are they actually being done, and what is the quality of the research. And here on the left side, you see top 10 by absolute volume of surgical RCTs. So 99, 2009, and 2019, you see a lot of the northern Scandinavian countries in there. You see a lot of the bigger countries by absolute volume, but when you go to top 10 by relative volume of surgical RCTs per 10 million inhabitants, you see that it is really the Northern European, the Scandinavian countries, and Netherlands. So it is a lot of the RCTs are being performed, and I do have to say that in our country, within our healthcare system, it is much easier for us to have the patients for follow-up, because that's a really a tricky issue for the US colleagues, and I fully understand that, and that's something you would really have to struggle with, because you do need the long-term results. Looking at the quality, the methodological quality of surgical trials that were included, we see that it actually gets better. But of course, there is still room for improvement, because strangely, when you look at the second line, or the three ones that I have outlined, is that if there is an RCT that does not explicitly state their primary outcome, that's really strange. And if you don't have a baseline data of the patients, that is also very peculiar. And then if you do not state how you have analyzed your patients, so is it intention to treat, everybody stays in their original group, or have you done it per protocol, which sometimes is clinically valid. So you really there is room for improvement, but we're getting a bit better, so this is really good. I would also stress the idea of because like I said, it is really a trial and tribulation to do an RCT. It takes funding, time, energy, a lot of infrastructure at the end, even though the funny part was that when we originally published the EPAC trial, actually Dave Flum asked me that what was the infrastructure for that, and I said you can actually read it on the paper. So everybody's all the names on the paper, that was the infrastructure. So we had no funding for the original trial. But I would really stress that even though it's not always possible to do an RCT, and you have to remember that RCTs are always limited by the idea that it's done in a specialized center in a selected patient population. So it may not be altogether applicable or generalizable to the real world data. And that's why large cohort studies and validation of RCT results in large prospective patient cohorts is really important. And you can, if you're working at a high volume center, you can always have a prospective observational cohort study, which is really it's really important, and really the validity of the data is so much better if you have a good prospective data collection instead of doing a single center retrospective series. So remember that, because observational cohort studies are really possible to do. And I think this is key issue, that when you do clinical surgical science, you have to have national and international collaboration. That's good for the brainstorming, that's good for the study design, and you actually are able to finish your trial in a sufficient number of years. So it's much better to play together instead of, not, because previously when I started my scientific career, there was still a lot of that kind of mentality that, I'm not telling you what I'm doing. So, and that is just plain stupid. So you really want to share your ideas and collaborate with your colleagues. And this is a good example of collaboration, which we're really trying to hook up. And initially it was just for type 2 diabetes remission. So a global IPDMA for all the studies that have sleeve versus bypass. I'm so happy to say that all the PIs and all the study groups have agreed to do this, and we're actually doing combining the whole data of all RCTs. So we will have a big randomized patient cohort, so we can use for multiple research questions concerning this. So I think this is really adds to the generalizability of the RCTs, as we did also already with the FASMBS trial, so which we combined our 5-year data showing that the patient populations between the two countries were very different, but that just adds to the generalizability of the RCT results, which are otherwise very specific. So I will end here showing my APAC study group, my SLEEVEPASS study group, and my PhDs. And if somebody would like to come to Malaga, the European chapter welcomes you. And just remember that really without data, you're just another person with an opinion. This is one of my favorite cartoons. So for all the researchers out there. So thank you very much for your attention, and happy to answer any questions.
Dr. Salminen, that's phenomenal. I mean, you answered quite a few questions that I actually had because, not all of us have gotten training in basic clinical researches, and we're not at a specialized center. And being in America, I have patients who change their insurance and then they can't come back to my hospital. So doing a long-term study is a little bit harder here. But in terms of
It's not a little bit harder, it's sometimes almost impossible.
right, right. And th this kind of collaborations, where can someone who's starting off, like Nathan and the rest of the fellows, what advice would you give them? How do they find these collaborations to join and kind of, add to the literature?
I would say that, the collaboration, like I said, I started and I hopefully didn't fade on that one, but I think the idea that you need to kind of network within the scientific parts of the Congress. You need to network within your own hospital. And remember, when we're treating obesity, it's not just surgery. So you're networking with a lot of different fields, and it's a multidisciplinary approach. But I think I would really stress the importance of networking. So get out there. You have to participate in congresses. You have to do it outside your own local congress. You have to do it internationally. And I think if you are interested, please try to find a good mentor. That I know that's a tricky part, but just focus on it. Be aware and kind of alert what's going on. Follow the literature and go listen to the talks. And I know a lot of the surgeon scientists are willing to, share their expertise and answer your questions, but I would really stress the networking within clinical work, within scientific research, and do the networking. It's really important to know your colleagues, and you always learn something, always, every single time.
Perfect. Dr. Park, you had a question for her.
And it's actually related to that. So I'm pretty early on in my career. I just became an attending not too long ago, and I have absolutely no disclosures, and you have so many disclosures. And I just have to ask, how do you balance it all? How do you do the whole duality of being a practicing surgeon, being a primary investigator, being a leader in industry, just being a human being? How do you balance it?
Being a human
And
being.
then you forgot the mother part there.
My goodness.
Oh.
Yeah, but that is a good question and a very tricky answer. I have two kids. They're already 27 and 24. So and they turned out very good in spite of me. So I think
That's
that's
awesome.
I think it is. I currently have, I think, I have 16 PhD students currently, and 9 have already finished. But I think I always tell them, like, with the balanced work-life balance, of course, mine is probably not that good. I still have to work on that. But you need to have life outside work, and I always tell my PhDs that maybe you stay in a few hours later than everybody else, but when you go home, especially if you have kids, you go home and you be with your kids, so you don't work when they are awake. So that's what I did. Of course, I worked after that, so maybe we should ask my husband who's sitting by me, but maybe not. So I think it is really a tricky issue to balance your work life, and then I think it's another issue to balance within your work life. You have your clinical work, because you have to do that and you have to focus on that in order to, excel in that. And when you excel in that and combine that with clinical research, it actually means that you're doing two jobs, because otherwise it is really not possible. So I think it is a matter of, focusing early enough, but not too early. So sufficiently early, you have to find your kind of your pathway, because you can't do everything. Like I said, I originally did a lot of oncology surgery. So but I was doing mainly pancreatic surgery, but that, I think would demand that you focus on that one, because you can't do it all. So that's why I decided to, set my focus on a more narrow field and focus on these things. I think that's crucial, but also not too early, because when you're doing surgery, you have to have a wide enough field of clinical experience in order to actually excel in surgery. So it is very challenging, but it's insanely fun. So that's why we do it.
That's a beautiful answer. It's fun. That's why you do it. You find satisfaction.
Yeah.
Cool. So I have a colleague who sent me a text instead of typing here, so I'm going to ask that question. In the US, it's from Dr. Hooper, Elizabeth Hooper. She said, in the US, we are seeing a lot of patients who are adding the GLP-1 medications. It's leading to the more muddy data on outcomes. Do you find that happening in Finland, in terms of patients having bariatric surgery, then getting on GLP-1s, and how do we kind of look at the outcomes when you have medications added to this, you know, to the
There are
treatment?
so many RCTs on that topic that should be performed. So we've had multiple discussions on that, but I think we have to look at GLP-1s and everything else that's coming out in the pipeline as another tool in the box. Because if you think about, like, you can't be narrow-minded that you think that it's just surgery, but you have to remember that we are currently treating only 1 to 2% of the patients that would
Right.
be eligible for metabolic bariatric surgery. So we're not treating 98% of the patients. So I think the medications, the OMMs, obesity management medications, are perfect in the way that they bring more people within active treatment. And it's going to be a step-up approach. And it can be, and I think it's going to happen. And we just wrote this position statement, actually, that's currently was accepted but not yet published, with Ricardo Cohen and a few other people, on the idea that a person may have GLP-1s before, but if they, for some reason, adverse events, costs, anything, they don't want to continue, you have to look at the indications for metabolic bariatric surgery from the baseline weight that we actually had the IFSO consensus on in 2024, that is the definition for the baseline weight, is before initiating any weight loss procedure. So I think we have to embrace it. Sometimes it is after the surgery. And I think the most interesting part, where I said that you would have to do a bunch of RCTs to figure this out, is that we probably should be able to phenotype patients a bit better, so in order to tailor that, who would actually benefit from GLP-1s or something else before surgery or after surgery. Would it be a specific group that would, we would actually have this treatment paradigm that we would combine? Because combining the treatments, that we already know that when you do the combined treatment, it is synergistic. So it adds on to the surgery. But how does it do it? So we need to look at the mechanisms and how to do it. But I think that it is a very interesting question, and we live in such an exciting time for this field because of all of these different options, and we need all the tools in the box. It's
Pivoting
all hands on deck approach.
100%. And I think absolutely one part of it is like research, and then what you're saying, we need more evidence. But the other part, which you kind of alluded to, we're only operating on 1 to 2% of the patients that qualify or that need the treatment. Now, in your mind, how do we reach out to the other patients, the majority of the pie? Do you think social media is going to play a role? And when you said that it takes 17 years, by the way, I didn't know that it takes 17 years. Wow.
It's crazy. It's crazy.
That's crazy, right? So do you think
Yeah.
AI is going to play a role in that?
I definitely think, and you're doing a very good job on your social media for that. And I think I think it's very important. We have to do it. And I know within IFSO, we have a lot of these initiatives that we're trying to do, make us older people do, shorter, videos that you can use on various social media platforms on really reaching out to the public, really reaching out to the decision makers, the policy makers. We just have to keep on, spreading the knowledge because we have the data. This is one of the treatments that we really have the data for. This is one of the most evidence-based surgical fields that I know. So
Right.
it is absolutely clear that, compared to just standard lifestyle and diet treatment, of course, we all know that, and the data is out there. We just have to bring it out and kind of also clarify that surgery actually is very safe, and we have to embrace all the other treatment options. So within surgery, as you are practicing within your obesity treatment, you have to have all the treatment options. You cannot be focused on just surgery. You have to have all the other options. And also within surgery, there cannot be such a surgeon that does only one procedure. So you have to have an armamentarium of procedures that you're able to treat the patients that you need to treat. And still, for the most complicated cases, remember that you have friends all over the world and people with long experience, so you can actually do the consultations and then really improve your quality of care.
Thank you. I'm very conscious of the time that it's 9:01. I would love to
Yeah.
ask a lot more questions, but we'll catch you at another time. Thank you so much
Yes.
for making this work. I mean, I
Thank you,
cannot
Faiz. No,
this one.
it was a pleasure, and this was such a fun memory because it is now we're parked outside of the tunnel and waiting for probably the cops to come and see what's the matter. So because we did not dare to drive
Awesome.
into the tunnel, so but that's good. So it was really, thank you for the invitation. I was happy to be
Yeah.
here. So
Have a great trip in Scotland,
thank
and
you.
we'll see you
We'll
soon.
see you.